Thank you. And I'd like to begin today's presentation by thanking the organizers for inviting me to share with you diagnostic challenges in low and middle income countries for the pandemic response. Over the next 10 minutes or so, I'd like to present the role of diagnostics in the pandemic response and the diagnostic challenges and testing to save lives and livelihoods, and then conclude by a slide on moving forward. I have nothing to disclose. At the very beginning of the pandemic, the Director General of WHO already urged countries to test. He said testing, isolation, and contact tracing should be the backbone of the global pandemic response. However, the role of diagnostics has evolved over the pandemic. At first, when the pathogen was first identified as SARS coronavirus 2, diagnostics are really needed to refine the case definition by testing all symptomatic individuals to confirm their clinical diagnosis. Testing rates also can help us determine the extent and speed of transmission by looking at how many are positive. And testing contacts is very important to interrupt the chain of transmission. However, months into the pandemic, we realized that asymptomatic and pre-symptomatic individuals can also transmit. So that means that countries need to be scaling up testing in the community to look for all those who may be infected but asymptomatic. But many countries decided to impose lockdowns to try and slow the spread of COVID, and also by testing healthcare workers or elder home workers to protect the vulnerable. And then as vaccines become available and variants of concern start to emerge, rapid tests are necessary for trying to ensure a safe environment for schools, workplaces, and mass gatherings in order to allow for economic recovery. Some countries also did arrival testing and quarantine to reduce importation risk for travel. And the role of diagnostics is now important in terms of surveillance to track variants of concern. There are three main types of diagnostics available: molecular tests to detect viral RNA, antigen tests to detect viral proteins, and serology tests to determine host antibodies. They have their optimal time to be used. Molecular and antigen tests are typically optimal for the first 7 days post onset of symptoms, where serology is for 7 to 40 days post onset of symptoms as the immune response matures. The first two can be used to confirm infection, while serology tests is used mainly for determine exposure and surveillance. While molecular tests is the gold standard because it's highly sensitive and specific, it's, however, expensive and not very accessible. Antigen tests, on the other hand, are much more affordable, but are less sensitive. The Director General of WHO has recommended that countries use the WHO guidance that was issued first in September of 2020, and then a new version issued on the 25th of June, 2021. Molecular tests is the gold standard for testing people with COVID-like symptoms. And in where molecular testing is not available, antigen tests can be used, but if they're negative, may be confirmed with a molecular test. There are, however, challenges with scaling up molecular testing because of the cost, the requirement for skilled personnel and laboratory equipment. And because of the in LMICs, results can take hours or even days because of the lack of capacity to do large volume testing for molecular tests. Although point-of-care molecular tests can be used, they are faster and can be used in communities, their supply is limited by the speed of manufacturing of both the equipment and the cartridge. And the global competition for reagents and tests led to inequity of access. So that's the first thing about the reality in low and middle income countries. And because of the lack of capacity to perform molecular testing, they're really difficult to confirm cases unless antigen test is used. There are also challenges in imposing lockdowns and border closures to slow the spread of the infection so that health systems will not be overwhelmed. Because even though for all societies, lockdown and border closures impose mental, social, and financial hardships, but in LMICs, the lack of a safety net to compensate for lost wages and save livelihoods makes prolonged lockdowns very difficult. On the right, there's a picture of a rice ATM in Vietnam that was set up by an entrepreneur to give free food that could be dispensed from what we know as an ATM for getting money. But this dispenses rice and other food for those who lost their livelihoods. But not many countries have that. There's also harm in lockdown for school children that we realize now. So in the early days, Africa was shut out of the diagnostic market. John Nkengasong, the head of the Africa CDC, said that African countries have funds to pay for reagents and tests, but cannot buy them. This is not only in Africa, but also in Peru, where because they don't have many places to do molecular testing, when they were 7,000 test results behind, they decided to use serology tests to screen for those who call up with symptoms or call up a hotline to say that they have symptoms. Our team would visit them in their home and use serology tests for IgM or IgG to know whether they are exposed. And if they're exposed, then they have to be isolated. But if they're negative, then another specimen is taken for molecular testing. And this resulted in the rapid community triage of symptomatic individuals, relieve the backlog and waiting time for molecular tests, and prevent the healthcare system from being overwhelmed. Now, it's not only that case detection is a problem when you don't have molecular testing capacity. In May of 2020, much of Africa's multi-billion-dollar cross-border trade was halted because of COVID-19 pandemic. The government of Kenya decided that truck drivers are a high-risk group and need to be tested by PCR. Before they could leave the port to carry cargo to different parts of Africa. But the results can take up to 2 weeks. And that resulted in a 90-kilometer traffic jam at the port of Mombasa in Kenya. In July, the International Organization of Migration came to the rescue and brought in rapid PCR testing to the truck drivers and tested 17,000 drivers giving the result in 24 to 36 hours. But not so many countries are lucky to have that as a bailout. So it's really important for countries in LMICs to think about the use of antigen tests, not only for symptomatic testing, but also as a means to screen asymptomatic individuals in schools, in workplaces, in mass gatherings, and for travel. But then the question is, who do you screen? How frequently do you want to screen? What tests to use? Because there's so many tests available, and where do you do the screening? Now, I want to give an example of the government of Cameroon decided that they want to control the SARS, spread of SARS by case detection and limit the mortality due to COVID. But also limit the socioeconomic impact of the COVID-19 by continuing activities and engaging communities. Cameroon would be hosting the Cup of Nations, the Africa Cup of Nations, in January of next year, and they need to have a strategy for a safe event. So the government of Cameroon decided that the national algorithm for COVID testing, they will start with an antigen test, and those who are positive will be isolated as a case, and those who are negative need to be confirmed by PCR, and this resulted in 60% of the cases being detected with antigen tests with no compromise for leaving in terms of sensitivity of case detection, because all those who are negative are tested by PCR. And so this saves the government a lot of money and allow for community triage in a very efficient manner. Now, WHO has not recommended the use of antigen testing for general population screening because of the low possibility of being a positive. And so, but Africa CDC, as a practical measure, recommended it for general population screening with the recommendation that any antigen positive result needs to be confirmed because you may have more false positive than real positives when the prevalence is low. So in terms of being able to allow the economy to recover, testing in schools, music events, sports events, Brazil has allowed pharmacies to do testing. And since there are 88,000 pharmacies in Brazil, that enable lots of communities to access testing. And many countries decided to introduce layered interventions to reduce the risk of transmission with the use of face masks, distancing, hand hygiene, and ventilation if it's an indoor event. All these are being tried in different combinations depending on the positivity rate and the risk of transmission. And so moving forward, what I like to say is that COVID-19 has exposed fault lines in healthcare systems and inequities in access to quality assured diagnostics, and now we know also for vaccines. The approach for LMICs must address these inequities and strive to save lives and livelihoods through layered interventions, as I mentioned, including testing. There's a need for public-private partnerships and initiatives, such as those in Vietnam, to support those who lost their jobs. And there's also very important initiatives right now to support local manufacturing of life-saving commodities, including testing and vaccines. Ultimately, to build back better from the pandemic response, we need more resilient healthcare systems with the diagnostic system, both lab-based and community testing, as the backbone of the healthcare system, with data connectivity to improve patient care and surveillance to provide early alerts of outbreaks and inform control strategies. Thank you.